So last time we were considering how we concentrate urine. And then we mentioned about how the filtrate or the tubular fluid enters into the collecting duct, but it's still not concentrated. And this is because the space between the collecting duct in the renal medulla and the interstitial space doesn't have an osmotic gradient. So what you do is that you secrete a hormone, ADH, antidiuretic hormone, that it is secreted by the pituitary gland, but it is produced, remember, by the hypothalamus, and that is going to make the transcription of aquaporins. So it's a transcription factor, ADH. So you create some aquaporins that is going to insert into this collecting duct, and then you start reabsorbing water. And that is going to lead to the first part of this concentration of urine. Now, that happens in a region of the medulla that is close to the cortex. Now, as this fluid moves down and then you absorb more water, of course, you start creating a concentration gradient deeper in the medulla. So the water reabsorption continues as you go down, and then that will lead to the concentration of the urine to be maybe up to 100 millismoles, but not higher, because in there is no more gradient. So here it is. So what you're looking at in this region, in this tiny portion, it is the space. So this is a magnification of this collecting duct going from the part of the cortex that is next to the medulla, and then since there is no concentration gradient between this collecting duct and the medulla, you will release, you will have available ADH, antidiuretic hormone, and then this fluid that started to have a concentration gradient of 300 millismoles. With the aid of this ADH, you produce aquaporins that get inserted into here, and through these aquaporins, the water will move by osmosis into the space outside of this collecting duct. So this is the superficial or the almost cortical renal medulla, and this is the deep. So as you absorb more water, then the concentration rises from 300 to 400, 500, etc., and you can reach a maximum of 1200. That's the maximum that you can concentrate your urine. And that concentration will vary depending on the state of hydration of the person. You don't expect for someone who has normal hydration to become so concentrated, but then as the physiological state varies, that's when the concentration varies. And everything plays a role for absorption, secretion, excretion of items within this fluid. So everything starts here. So you filtrate your plasma in the glomeruli. The filtrate goes into the capsule, then it goes into the PCT, where you absorb most of the water, most of the organic molecules like amino acid, glucose, etc. And then as it moves down into the loop of Henle, the descending and ascending limb, you change the concentration because you have different solutes and water concentration within this interstitial space that surrounds the loop, and also that is between the loop and this blood vessel. It can be a pretubular capillary, it can be the vasa recta, and of course there is going to be a change between this loop and the blood vessel. And then here at the DCT, you will excrete molecules that you don't need, and then you will start absorbing water as needed, same as in here in the collecting duct. And now remember that this is just for forming urine, but also at the same time you control the concentration of hydrogen ions. Because if someone has acidosis, if he has a lot of hydrogen ions in their body, they start secreting them in here. Or if the person has alkalosis, if he needs hydrogen ions because the hydrogen ions are low, well, there is no purpose to get rid of them. So you will reabsorb them in here. And as well, what you do is you produce bicarbonate. Bicarbonate serves as a buffer. So the kidneys also regulates the pH balance and water concentration in our body, volume. What are the components of urine? Water, sodium, potassium, chloride, any ions that you have in your body. And wastes like urea, creatinine, ammonia, etc. We already saw this. And then there is this study that is called urinalysis that determines if someone has problems by looking at different things, like including not only the osmolarity of the urine, but also the presence of molecules like bilirubin, also the specific gravity, the presence of proteins, glucose, etc. So that you can do with urinalysis. Color typically is yellow, and the intensity, it depends. If it's diluted, it's going to be light yellow color. If it's concentrated, the urine is going to be dark yellow color. And then the pigment that gives the urine its color is called a urochrome. It comes from degradation of hemoglobin. Hemoglobin, the heme part, is going to be producing these urochromes. And then also certain things in the urine, it can give color. So for instance, if someone ingests vitamins, some of these vitamins, they have a coat with a color dye, and then you go and urinate and it's a little bit darker than usual. Something that it is, I think it's very important, it's that we notice changes in color in the urine. But there are certain changes that pays more the attention to you than anything else. Someone may have, for instance, glomerulonephritis, and the person will have the excretion of proteins, like, for instance, albumin into the urine. And then the person doesn't notice that. But then with urinalysis, you can detect the presence of proteins. And, well, when the person loses these proteins, the person is going to have edema. So the fluid, instead of staying within the circulatory system, is going to go into the interstitial space, and the person is going to look puffy. That's one of the signs of glomerulonephritis. But what if the person has plainly blood in the urine? That is called hematuria instead of hemoglobinuria. That triggers the person definitely to go to the doctor, because that's a macroscopic sign that something is wrong. Translucency. So our urine is clear. unless you have a bacterial infection, or you may have large quantities of proteins, or you may have, in this case, some fragments, like if someone has urinary kidney stone. The urine typically has an odor that, it's urine, but the odor shouldn't be malodorous, or it shouldn't have like a strong smell like ammonia. If that happens, the person may have a lot of nitrogenous wastes, and that can be due to several factors, including diabetes mellitus, the ingestion of certain foods, such as asparagus, that will alter the odor, or in general, since males, they have greater metabolism of muscle and nitrogenous wastes, they tend to have a stronger smell of ammonia in their urine. pH is around 6, but can vary between 4.5 and 8. What type of pH is 6? Acidic or basic? What is neutral pH? 7 is neutral pH. And then 6 is acidic or is basic? Acidic. Anything below 7 is acidic, anything above is basic. So, why do you think the urine is acidic? What is the physiological purpose? Why do we want to have acidic urine? Especially as you flush it out of your body. To get rid of what? Bacteria. Of bacteria. You have physical action. You flush away the microbes, but also the microbes will be not thriving because that acidity kills the microbes. Our urine is supposed to be sterile. It shouldn't have any bacteria or even white blood cells. A specific gravity is higher than distilled water, which is 1, so it's 1.001, which is, in the case of urine, very dilute, or 1.035, very concentrated. So, to do your analysis, sometimes you use these test strips that are deep into urine, and then you read these presence of molecules like blood, protein, leukocytes, glucose, etc. And it tells you if something is wrong. Now, for renal clearance, we'll be measuring the removal of particular substances within the blood. So we have an example here. So we have creatinine, which is the waste product of muscle metabolism. So when someone has creatinine levels above 1.2 milligrams per deciliter, this is abnormal because we don't retain this product. But this can vary depending on age, sex, and body mass. Typically, people who has greater body mass will have greater levels of creatinine, and males, they do have greater levels of creatinine in the blood. And then indirectly, the renal clearance help you to tell whether you are filtrating or not. So this measures the GFR, glomerular filtration rate. So we have another molecule that is called inulin, that it is found normally in foods like garlic or artichokes that are not reabsorbed nor secreted. So this is a good molecule to test the GFR. So if someone have an injection of inulin, that inulin, it is measured with time to see how effective you have the clearance of inulin from your body. And indirectly, of course, you will tell the GFR, because how many milliliters per minute you are filtrating in your glomeruli, and that tells you whether the person may have a kidney problem, like renal failure, for instance. Okay, so that's formation and concentration of urine and study of urine. Now let's look at urine transport, storage, and elimination. So once you form the urine goes from the pyramids into the papilla, and then from the papilla goes into the minor calyces, major calyces, and then into the renal pelvis. That is like a funnel. So all the urine of the kidneys goes first into the renal pelvis, and then the renal pelvis extends a tubular organ, that is the ureter, that connects into the urinary bladder. And then within the urinary bladder, we store the urine temporarily, and then ultimately the urine ends in the urethra and then outside of the body. And the elimination of urine is known as micturition. For the ureters, they are a couple of tubes that measure between 25 to 30 centimeters. So it's a little bit longer than 10 inches, and they have a small diameter, 3 to 4 millimeters, which is 1/6 of an inch or so, or 1/8 of an inch. And that's in the adult, and they begin at the level of the second lumbar vertebrae, and then they travel behind the peritoneum to connect the upper part and posterior part of the urinary bladder. It has 4 layers. The most internal, which is the epithelium, which is transitional epithelium. The transitional epithelium ranges from simple cuboidal to simple squamous, and this is because when the ureter is transporting the urine, the cells will squish, but when it's not transporting the urine, the cells plump. So squamous and then cuboidal. And then the next layer will be the muscularis layer, where you have a circular layer and then you have a longitudinal layer, and this layer is made out of smooth muscle cells that contract and relax to transport the urine through peristalsis. And then the last layer will be the adventitia, which helps to connect these ureters to the surrounding tissue. It's made out of fibrous connective tissue. And then the movement of peristalsis, it happens, the contraction relaxation, 5 times per minute. So then something that happens, because this lumen inside the ureters is very tiny, is like if someone has a kidney stone. As this kidney stone, if it migrates from the kidneys into the ureters, that peristalsis will basically make the kidney stone, as it's traveling, to squeeze the kidney stone, and then the person is going to have damage to the internal epithelium, and then will have bleeding. Because some of the spikes of the stones can damage this epithelium, go a little bit deeper into the subsequent layers, and then that creates this bleeding. And then that peristalsis can become strong, and then the person will have very sharp pain, and then it's going to be intense pain. Details about the urinary bladder is a sac, muscular sac, that holds urine. and it is distensible. It is suspended by the parietal peritoneum in the sac of Douglas that is located, in the case of females, between the vagina and, between the uterus and the urinary bladder. And when it is empty, collapses and then becomes pear-shaped when it's distended. It says here that it can hold between 700 to 800 milliliters of urine. I guess it can hold more, sometimes like 1 liter or so of urine. So it has also several layers, like the urinary bladder, like the ureter. It has the adventitia, which is the most external part that it helps to connect it into the surrounding tissues. The muscular layer is called the detrusor muscle. It's the middle layer. It's a smooth muscle cells arranged in the inner longitudinal, middle circular, and the outer longitudinal layers. And then you have a circular band, which is the urethral sphincter, internal urethral sphincter, in between the urethra and the urinary bladder. So this sphincter opens when the urine is coming from the kidneys into urinary bladder, and then it closes. So this is the internal urethral sphincter. And then you have a mucosa where you have still the transitional epithelium. And this, again, this epithelium is just like as the epithelium of the ureter. So when the urinary bladder is empty, the cells plump, so they become cuboidal. And as this urine is being accumulated, the cells squishes, and then they become squamous. So it's a functional transition. And the urinary bladder, when it's empty, it has folds of the mucosa, which is called rugae, just like the ones that we have in the stomach. So this rugae disappears when the urinary bladder is full. So think about the state of your rugae of your urinary bladder right now. Do you have them or you don't have it? Well, if you don't feel like you wanted to go to pee, you have the foldings, you have the rugae, but as the urinary bladder gets full, this rugae disappears. Internally, in the mucosa, there is a space that is called the trigone. This is the floor of the urinary bladder. And in this region, there is no rugae. So it's actually the space between the two openings of the ureters and the opening of the urethra. And it's low and it's a little bit posterior. And the urine, as it flows from the urethral openings into these between the two ureter openings and the urethral opening, as it flows like this, it carves it, it makes it like to be very smooth. So you don't have again these foldings. So this is the different structures of the ureters and the urinary bladder. So again, the ureters are long extensions of the renal pelvis that connects into a urinary bladder, bringing the urine from the kidneys into a urinary bladder. If you make a section of these ureters, and if you see internally, you can see the lumen, the mucosa with this transitional epithelium, then the muscularis, and then the adventitia. Here is the urinary bladder, the superior part covered by the peritoneum. And then here are the layers. The adventitia, this is external, then the detrusor muscle, and then the mucosa. Here is where you have the rugae, and then in this part between the opening of the ureters and then the urinary bladder, the urethra, you have this smooth surface, which is called the trigone. And then here at the neck, this is the neck of the urinary bladder, you have the internal urethral sphincter, which is involuntary, and then here you have the external urethral sphincter, which is made by the skeletal muscles. It's part of the urogenital diaphragm. This is voluntary. So if you take a section of this part of the urinary bladder, you can see this transitional epithelium and the muscularis in here, and this is the lumen. So again, as the urine comes through these ureter openings and then goes into the bottom of the urinary bladder, it makes this surface to be smooth. And this is folded. The foldings disappear, the rugae, until you have a full urinary bladder. Who cares about the trigone? We all should care. Our urine goes and stays longer time in this region because this is the lowest region of the urinary bladder. Urine has only waste products, toxins, and nitrogenous wastes that can damage our cells. So bladder cancers, urinary bladder cancers, happens more within this region than in these other regions. That's not a necessary reason for you to go and pee every time because you want to prevent having urine in this region as much as you can. But of course, you expect that for longer than the person holds the urine in their urinary bladder, then of course the longer that you expose that epithelium in the trigone to be exposed to things that perhaps can damage your cells. Okay? Sometimes some things can irritate your epithelium in your urinary bladder, and that prevents the formation of mucus in your cells. This is called interstitial cystitis, or IC. So one sign and symptom, some signs and symptoms of this interstitial cystitis is frequent urination, pelvic pain, and mucosal ulcerations. This not necessarily has to be a UTI. Someone can have interstitial cystitis without UTI, or it can have both. So unfortunately, once the person develops this interstitial cystitis, the person responds poorly to treatment, and over long term can lead to scars inside the urinary bladder and contraction. So that leads to less distension of your urinary bladder and incontinence. Questions? Okay, urethra is the terminal portion of the urinary tract, drains urine into urinary bladder and to the outside of the body. It's just a muscular tube, just like as a ureter, and it has as well an adventitia, middle muscularis, and inner mucosa. So this one as well undergo peristalsis to transfer the urine into the outside of the body, and it is surrounded by the internal urethral sphincter, and then the external urethral sphincter is formed from the muscle that is called levator ani muscle in the urogenital diaphragm, and this is the one that is under voluntary control. Now, in females, the urethra is short, it's 4 centimeters in length, almost 2 inches, and opens into the external urethral orifice between the vagina and the clitoris. In males, it's long, it's 20 centimeters in length, and it has 3 portions. It has the portion that it is surrounded by the prostate gland, so we will see this again in the reproductive system chapter. So this is called prostatic urethra. The second part, which is very short, it is located between the muscles of the pelvic diaphragm. This is called the membranous urethra, passes through the levator ani muscle. And then the longest part is the one that is inside the penis. It's called the spongy urethra, and it is located in the spongy body of the penis. So here is the medial view of these organs. So here we have the urinary bladder, and this is the urethra in females. It's short, and then in males, this is the prostatic urethra. This is the membranous urethra, and this is the spongy urethra or penile urethra. And this opening is the external urethral orifice. The process of micturition happens because we have a reflex. So this reflex is mediated by parasympathetic nervous system, the spinal cord, and a short and a long reflex between the sacral nerves and these parts. So we have in the wall of the urinary bladder stretch receptors that they send action potentials as they're getting distended. As they sense the pressure as the urinary bladder is distended. So these stretch receptors are connected to sensory afferent nerves that brings the information into the spinal cord at the level of the second sacral nerve and the third sacral nerve. And then that information is going to be conveyed into the efferent nerves from the parasympathetic nervous system that makes the detrusor muscle to initially contract so that you can control, control the volume of the urine. And then not only to this detrusor muscle, but to the internal urethral sphincter so that you don't relax this sphincter. So then once you have your urinary bladder full, then you will send a signal that is afferent into the cerebral cortex, and the cerebral cortex will send an efferent signal that goes into the spinal cord, and then you send through these sacral nerves a signal, an efferent signal, into your urinary bladder so that the detrusor muscle can contract, and then you can relax the internal urethral sphincter, and then that will cause micturition. So as a child matures, the pathways develop that allows control over the external urethral sphincter, which is the one that it is voluntary. Now, you have interneurons in between this parasympathetic nervous system and the sacral nerves that signal the micturition center in the pons so that you can control micturition if it's appropriate. And then you can relax your urethral sphincter and you void the urine. So this cycle will repeat every hour, and if you reach a volume of around 500 to 600 milliliters, that's enough for you to have micturition, regardless. So here are the reflexes then that controls micturition. So again, in this case, we have a full urinary bladder with completely stretched receptors, the baroreceptors that sense an afferent signal at the level of S2, S3, and then you have an interneuron that brings this information into the pons initially, and then later you can combine that into the cerebral cortex, and then if it's necessary, you send that information down through another interneuron into these nerves, the sacral nerves, that controls this external urethral sphincter. If it's completely full, you need to go to pee, you will relax this and this at the same time, but if not, you have this contract while this one is relaxed. And sorry, for micturition, this too has to be relaxed because then that will lead to the urination, but when it's not necessary, this one is initially contracted while this one is relaxed, and then your muscles or the trusor area in your urinary bladder will contract accordingly. In the case of voiding, they will contract powerfully so that you can initiate micturition. So that's all for this chapter. Do you have any questions?